morning, good afternoon, and good evening, our viewers. My name is Richard Chakwajuko. I work for the USAID Local Partner Health Services Ankole and Acholi activity that is implemented by the AIDS Support Organization, TASO. I'm here to share with you how we manage to accelerate community-differentiated service delivery models to improve continuity of treatment among persons living with HIV in the post-war ravaged Acholi sub-region in Uganda. Before I deep dive further, I want to acknowledge my co-authors. That is Dr. Anna Lawino, the project director, Agatha Angwech, our communication specialist, and Noah Kasunumba, our M&E manager. Minister of Health Uganda, in her 2020 consolidated guidelines, did recommend differentiated service delivery models for persons living with HIV. The recommendation was for prevention, care, and treatment to meet the needs and preferences of clients. Core to this DSD guidance was client-centered approach, but then also to improve clinic efficiencies. The DSD guidance did recommend DSD models for which clients could best benefit. These included both facility and community-based models. Among the facility-based models, we have the facility-based individual management, the fast-track drug refills, the facility-based groups, and among the community models, we have the community drug distribution points, the community retail pharmacies, and the community client-led ART delivery approaches. For the Acholi sub-region where I operate, we are located in the northern part of the country, Uganda. And this area was faced by a 20-year civil war that ravaged the entire healthcare system. The project TASO supports 70 ART public facilities that has 46,413 persons living with HIV. And as of December 2021, 2,422 persons living with HIV had interrupted with their treatment. And 91% of the adults had viral suppression, while 73% of the children and adolescents living with HIV had their viral suppressed. The USAID Local Partner Health Services Ankole Acholi activity that is implemented by TASO conducted a root cause analysis to determine the barriers to continuity of treatment among persons living with HIV. This was conducted in February 2022. Persons living with HIV on ART who had missed their appointments were interviewed by health providers at both community and at facility. Using the root cause analysis information, the data that was collected was later on reviewed and analyzed using the Pareto chart. I have a slide that will be showcasing the Pareto chart and the barriers to appointment keeping as demonstrated by the persons living with HIV. In this root cause analysis, 606 eligible clients were interviewed, of which 34% of them were aged between 30 to 39 years of age, and 65% of them were females. 90% of these clients were in facility-based service delivery models, of which 41% accounted for the fast-track drug refills. They had largely been in care for at least 6 months period of time. The main barriers for continuity in treatment were distance for getting appointments, sickness, and transport issues. So as a program, we came up with an improvement aim of mitigating attrition through optimizing client preferences and offering client-centered care. This was done through accelerating enrollment of stable clients in DSD models of choice and using the DSD client preference tool for persons living with HIV. The DSD client preference tool aimed at understanding client preferences for ART service provision, including community linkages and support services. It provided an overview of patient preferences for antiretroviral therapy services to aim at a more responsive stature for patient needs. It targeted persons living with HIV on ART at both facility and community-based models. We had to roll out the DSD client preference tool across our districts, and we started with stakeholder meetings at districts, health facilities, and communities to start with the dissemination of the root cause analysis findings for the barriers for missing appointments and the orientation of health care workers on the DSD client preference tool. We selected 10 public health facilities, including 2 hospitals, 4 health center 4s, and 3 health center 3s. The selection of the clients to be interviewed was based on a standard operating procedure that clearly described the selection of clients from all the DSD models, and this was further disaggregated according to the age bands and by sex. The administration of this DSD client preference tool was done at both community and facility through both physical and virtual interviews. As I speak to date, the DSD client preference tool has been scaled up to all the 70 ART sites that are supported by the USAID Local Partner Health Services and Kole and Acholi activity being implemented by TASO from the 10 facilities. At my extreme left is the DSD client preference tool that we use to support this improvement aim. We have observed the results from this DSD client preference tool highlights, and we start with the DSD preference. We did observe that 61% of the clients interviewed were in their preferred DSD approach, while 39% of the clients interviewed did say they were not in their preferred DSD approach. When we looked at the variable of DSD model preference, we saw that fast-track drug refills and the community client-led ART delivery were the most preferred models of care, with fast-track drug refills accounting for 40.3% and the community client-led ART delivery accounting for 21.3%. We looked at the variable of missing appointment versus the differentiated service delivery model, and did observe that 40% of the clients' missing appointments were on facility-based individual management, and 30% were on fast-track drug refills. We also analyze data on the vial load by differentiated delivery service model approach, where we observed that good vial load suppression did exist among community models, that is, the community client-led ART delivery and the community drug distribution points. Facility-based DSDM models had the lowest vial load suppression rates, and this clearly explains why we need to focus on scaling up community drug distribution models. Reviewing multi-month drug dispensation against the DSD approaches, we did observe that 86% of our clients on treatment had received more than 3 months of drug dispensation, while 38% of our clients had received over 6 months of drug dispensation as of financial year 2022, quarter 4. And we also did observe that there was an increased uptake among community-based models, and in particular to say, we had an increment in the number of PLHIVs that were taking up community drug distribution points, and we had a reduction in those that were taking up the fast-track drug refills as of end of quarter 3 of the financial year 2022. All these results are available on the slides as indicated. We also did observe interruptions in treatment trends over the quarters, and there was a reduction in the number of enrolled persons living with HIV that were interrupting with their treatment. In financial year 2022, quarter 1, we had 2,256 persons living with HIV that had interrupted their treatment. This reduced to 1,490 as of financial year 2022, quarter 4, which is a very good result attributable to the community drug distribution points. There was improvement in vial load suppression among children and adolescents living with HIV, with 73%. There was improvement in vial load suppression rates among children and adolescents living with HIV. In financial 2022, quarter 1, we had a suppression rate among children and adolescents living with HIV of 73%. And in financial year 2022 Q4, this had improved to 82%, which is also a great achievement. The photo outline out there describes one of the community-based models where the health workers are deliberating on health education sessions. As I conclude, we observe that root cause analyses are simple approaches aimed at determining structural and client-level challenges to HIV treatment, and applying differentiated delivery service client preference tool integrates client-centered care, and it is helpful in mitigating challenges affecting treatment continuity. Significant improvement in processes of HIV care is possible with the optimization of client preferences for service delivery models, and accelerating enrollment in community differentiated service delivery models improves continuity on treatment. I want to acknowledge USAID, Ministry of Health Uganda, the districts and health facilities of the Acholi sub-region in Uganda, the AIDS Support Organization, TASO, implementing the USAID Local Partner Health Services, Ankole and Acholi activity, and the URC USAID Rights North Acholi activity. I thank you very much.